Hi, today we will discuss about muscle stabilization procedures during amputation. Historically, 4 types of muscle stabilization can be accomplished via surgical means. These include simple myofascial closure, myoplasty, miodesis and tenodesis. Myofascial closure encases the transected muscle by closing the outer fascial envelope over the top of the muscles. Myofascial closure in and of itself is not an effective means of muscle stabilization as it provides only minimal stabilization for the most superficial muscles, and provides inadequate distal attachment of the muscular tissue to the bone. It is primarily used when severe ischemia prevents more effective means of distal muscle fixation. Myoplasty, the second technique, is one by which the surgeon brings the muscles over the end of the bone and sews them to opposing muscle groups. Unfortunately, unless these muscles become firmly stabilized by scar tissue, the attachment can work antagonistically as a muscular sling, sliding back and forth over the distal end of the bone. This motion of muscle sliding over the bone is not good. It often creates bursal tissue and discomfort, both of which are easy to identify upon examination. Motion and an accompanying crepitance will be palpable over the end of the bone on physical examination. Because of the frequency of these complications, simple myoplasty is not recommended and the surgeon should instead attempt to secure the tissue directly to the distal end of the bone. If the muscle groups themselves are attached directly and securely to the periosteum or the bone, it is called miodesis. In miodesis, the deepest layers of muscle are typically secured directly to the bone, while the more superficial layers of muscle are sewn to each other as a myoplasty. Tenodesis is very secure but frequently anatomically impossible. Tenodesis involves the firm distal attachment of the severed tendon down to the bone, and is the most physiologic and effective means of muscle stabilization. It is possible only when the muscle belly itself is not transected and the tendon is intact. Tenodesis is most commonly used in disarticulations, and is the primary method in knee disarticulations in which the patellar tendon is secured to the origin of the cruciate ligaments on the distal femur. Whenever anatomical circumstances permit, distal attachment of the muscles, tendon, fascia or aponeurosis directly to the bone should be performed. New technique, agonist-antagonist myveneral interface is introduced in 2017. The distal tendons of agonist-antagonist muscles were first identified and transected near their insertions. Both agonist-antagonists were then isolated from surrounding tissues and wrapped in opposite directions around the bone. The distal tendons were coated with 5-0 nylon suture, with special attention given to ensuring that the resulting crystal signals at rest match the rest signals from the physiological. Patients also experienced less pain and less muscle atrophy following this surgery, which is known as the agonist-antagonist myveneral interface. So far, about 60 patients around the world have received this type of surgery, which can also be done for people with arm amputations. Song says that, because of the AMI neuroprosthetic interface, we were able to boost that neural signaling, preserving as much as we could. This was able to restore a person's neural capability to continuously and directly control the full gait, across different walking speeds, stairs, slopes, even going over obstacles.